Okay, or
Hello and welcome. And today I'm very pleased to introduce Dr. Raymond Perrin, who is you are an osteopath.
yes,
Presumably that's where you started,
yes, and I'm also a neuroscientist as
a
well.
neuroscientist.
That's where my doctorate is in the field
Right.
of science. Yeah,
And today we're going to talk about Raymond's new book called, I always do this, I hold it up and it never works, but it looks like it's working, Through the Looking Glass, which is a lovely title until we start going to the dramatic bits about it. Diagnosing and treating long COVID using the Perrin technique, which is what we're going to discuss today. And how the symptoms of long COVID can be reversed by lymphatic drainage of the brain. That's the bit that doesn't sound so great as opposed to, Alice through the looking glass.
yes, I know. There are quotes in the book, Katrina, of Alison through the Looking Glass and
Yes.
other of the Lewis Carroll books. So each chapter begins with a relevant quote from one of the books of Alice. But the reason why I used that title was because on the day that the pandemic was announced, which was March the 11th, 2020, I that was a day that I remember very well, and most people do when the World Health Organization announced it as a worldwide pandemic. But it was also the day of my anniversary, and my wife has just about forgiven me for staying up all night on that night and writing a paper. And we called the paper, my colleagues and I at the University of Manchester, here in the UK, we called it we called it Into the Looking Glass, as though we were looking ahead after the pandemic had died off. We said that there'll be a further sort of pandemic of a post-viral condition. And the reason why I knew this, and I had to get it out first because I knew that this would be so relevant in the future. And now we see, and the reason why I knew this is because of all my work for 36 years on ME, chronic fatigue syndrome, post-viral, as it's also known as, conditions. And my research led me to understand the condition. And I knew that in the first COVID pandemic epidemic, which was SARS-1 in Canada, which went from Hong Kong to Canada in 2003, that wasn't a pandemic. They managed to curtail it in Toronto. But when it got to Toronto, a lot of people died. There were a lot of people that died of it. But the ones that survived it, a lot of them developed this post-viral fatigue, ME, as we know, myalgic encephalomyelitis, and so also known as chronic fatigue syndrome. And this condition was highlighted by professors in Toronto. There was a chap called Harvey Moldovsky did postmortems and showed that the buildup of poisons, of toxins in the brain, of inflammatory products in the brain that caused the death of these patients had come from the virus and gone through the olfactory pathway, which is a pathway of smell, from the brain down to the nasal cavity. And this pathway was a major significant part of my whole research into ME. And they said they'd found it gone through this pathway into the brain and caused inflammation in the brain and caused the conditions that we saw post-viral in SARS-1. And this was SARS-2. COVID-19's original name was SARS-2. So it was a virus very similar, spike protein virus, very similar to SARS-1. And so I said, if it's a worldwide pandemic, not just a few hundred people are going to get this, it's going to be a few million, maybe many million. And now we have an estimate of around 65 million people with long.
Yeah, I saw that in your book, and I think you said 2 million in the UK. I mean, it's just, and they're the people that have come forward to say they've
Yeah,
got it.
absolutely, absolutely. And I said it's a form of ME. It's just another name, and it's going to
Mm.
fit into ME. And that's what we're seeing now. New studies coming out all the time showing that ME and long COVID are virtually the same pathology, same findings, same symptoms. And so I knew this was going to happen because I felt right from my original research from 1989 that we were dealing with a problem of drainage of toxins from the brain. Now, when I came up with this idea, it was completely against medical thinking, and that's no exaggeration because I started my work in 1989 into ME with one patient who came in. I was working as an osteopath in Manchester, in a clinic in Manchester, and he came in with problems in his spine, problems in his lower back and his neck and his shoulders. And he was a cyclist. He had cycled professionally for a team that I used to look after in Manchester, the Rally Banana team it was known as. And so I said, well, I can help your back problems. And he said, I've also been off cycling for 7 years because I've got ME. And I said, well, if you got ME, I don't know much about it. We had one lecture on psychosomatic disorders. Remember, in those days in the 80s, it was called yuppie flu. So there was
Yeah.
a very derogatory ideas about ME that in those days very few doctors believed it was a real illness. So I said, well, I'll treat your back and smile at the patient. Tender loving care might help him. And his symptoms of his spinal problems sorted out. I was an osteopath specializing in sports medicine. This was my baby. I could do that. But he'd said that his symptoms of ME, as I was working on his spine and getting his posture working better, had improved. And within a few months, he was completely symptom free. So he was the one that started me off. And he said, you've
Mm.
cured me. I said, no. So he said, you have. I've been everywhere and you've got me better. I said, well, I don't know how. So he came with a whole wad of of research papers that he'd looked at, loads of stuff he'd investigated over the last 7 years. And he said, here, read this. So I did. I've always been an inquisitive sort of person, so I decided to look into it.
Do you think it's because how you've have maybe approached it in a different manner to how a standard doctor would be? Is because an osteopath is more in touch with how the body flows as a whole.
But
And
absolutely, absolutely.
and I also noticed, because I'm a great believer in functional medicine, and I noticed that you have an extract in your book about somebody that you obviously think it's a great idea as well. And that's how how you managed to break through.
Well, yeah, I mean, functional med. I work with a lot of functional medical doctors, and I mean, one of the leading functional medical practitioners in the UK wrote the foreword for my book because he was helped with the Perrin technique, and
Mm.
he used functional medicine as well. But the main stay of his improvement, he felt, was having my treatment by one of my practitioners for long COVID. I was, but I've been lecturing all around the world, and I was lecturing in Anchorage a few months ago in Alaska, and one of the doctors that came to my course for learning the techniques wasn't an osteopath, wasn't a functional medical doctor. He was a specialist in infectious diseases.
Mm.
He came all the way with his wife from Tucson, Arizona, which is a long way to Alaska, and he came all the way to study under me because he had long COVID. And as a function, as a specialist in infectious diseases, he had nothing he could do for his long COVID. But he found a practitioner that did my techniques, and that's what got him better. So he
So,
came along and learned the techniques, even though he'd never done manual therapy before. But so
wow.
teaching doctors how to do the manual treatments and but osteopaths are trained to look at the body as a functional. The principle of osteopathy is, which was taught right from the word go from Andrew Taylor Still in the 1870s, was function governs structure. Structure governs function. So if the structure's right, the function of the body will be more correct. And so we've always looked at getting the body working better structurally, but this was much more than that. What I found with ME was something much more than just getting the structure of the body correct. It was working on the fluids. And I realized that very early on in my work, I realized that we're dealing with fluids and the backflow of fluids. And there are physical signs that I found that show this, that there's a backflow of lymphatic drainage. And I thought, how can that happen? So we have varicose veins when the veins stop working. You see the bobbly veins that happen after pregnancy sometimes, and in elderly people you have a lot of varicose veins in the legs. These veins are because the valves of the veins as time goes on stop working properly and they build up and the blood builds up. But varicose lymph, never. We weren't taught anything about varicose lymphatics. And I found the work of John Kinmont, who was a leading specialist involved in lymphatics, and he wrote a book talking about, and papers talk about, there's a backflow of lymph in disease states. But his work was never proven. And I took on the mantle of trying to prove that there was a backflow of lymph. And I did with photographs. I have a photo in my book. And in fact, in the non-COVID book, we've got a new photo of showing varicose lymph throughout the whole chest of a woman. And these are colorless vessels that are huge. And they should be only 0.5 millimeter wide. The lymph vessels of the surface should be only 0.5 millimeter. And these are almost 0.5 centimeter wide. And they're colorless because lymph is a colorless fluid near the surface of the skin. So these are not, so this was a finding I found very early on in my work. And I found other findings about the spine. There's always a problem in the spine in all these patients. You won't find a healthy thoracic spine, which is the upper part of the back, in any ME patients, in any fibromyalgia patients, and in any long COVID patients. There's always a problem there. And we can see.
Is that a common, do people know that? Is that like a common fact?
Well, it's something that I did research on, and we published a paper in 2007. So it's 8 years ago now. This paper was published in the British Medical Journal. It wasn't in the Osteopathic Journal. But in there, we looked at the 5 physical signs that I've discovered in all that are common to all these ME patients, are common to all fibromyalgia patients, and are common to all, as we're seeing now, long COVID patients.
And when you say ME, are you also including CFS in
Well,
that?
ME, CFS, yeah. Patients like the word ME. Doctors often like the word CFS. So the compromisers call it ME-CFS, yeah. So that's
right, okay.
So that's the term, but because it can cover chronic fatigue syndrome, can cover lots of things, but so we call it ME-CFS. And
yes.
myalgic is when it was first termed by Donald Akerson in the 1950s. It was called that because of myalgic was a muscle pain. Encephalo, it had something to do with the brain, and myelitis, there was inflammation of the spine. And we see this in virtually everybody. Some people don't get inflammation, but we see problems in the spine. So I was looking at the spine and I wrote papers on it, and I started looking at the lymph and I started writing papers on that. And then I started doing more and more research, and my thesis was published 2005, showing evidence that there was a drainage system of the brain that was going in the wrong direction, in the spine that was going in the wrong direction. And that led to a buildup of toxins in the central nervous system, causing all the symptoms we know today. And in my book, I list, in my book on chronic fatigue, ME, chronic fatigue, the big book I have, the Perrin Technique, second edition, there's over 100 different symptoms that people have related to this fact that this drainage system doesn't work. And so we see this again with long COVID, exactly the same. Right. So there's loads and loads of symptoms that is all because the toxins are building up and going up into the brain. Remember, the first symptom of COVID was anosmia, was loss of smell. Then it goes into the brain and into the area of the brain called the hypothalamus that controls fever. And then that went wrong because the toxins were building up, and this caused fever. And then it spread out throughout the brain, causing all different disturbances of brain function, brain fog, cognitive problems. And it also affects the limbic system, the emotional side of your brain. So it's all, so it does cause major mood swings with patients. And then if it goes further back, it can cause problems in the back of the brain, causing problems in movement. So it can affect the sight. It can the drainage of the brain exists, but we were never taught that.
I think you mentioned it in your book that the diagnosis, when somebody presents certain symptoms,
Yeah.
they can go through a whole range of, the doctor can go through a whole range of other things other than long
Yeah.
COVID, maybe.
Yeah, absolutely. They go, I mean, it's same with ME. It's diagnosed by exclusion. They'll test you for
Yes.
everything and everything and say it's not this, it's not that, it must be exclusion. I say to patients, could you imagine a doctor saying
Yeah.
to you, we've tested you for everything. We can't find anything else wrong with you. It must be cancer. We'll start chemo tomorrow. They'll be
Yeah.
struck off.
Yeah,
They'll
I
be
read that
struck
in your
off.
book and it kind of made me smile because that's so true. And, the feedback that I get from all of our members is the frustration of, first of all, as you say, people don't believe them. They don't believe themselves. They then
Yeah.
go into the vicious cycle of depression and all what that then moves forward and presumably makes everything worse to start with.
My name for ME is TP, and also for long COVID, it fits TPOS. And I don't know if I can say it on public, but thoroughly beep beep off syndrome.
Yeah, I think that's it. And I mean, what's really nice, we haven't actually spoken about your physical book, and I always love talking about people's physical book. And what I really liked about your book is I love it when there's diagrams and there's different chapters and there's things in different colors, and that you've got a really neat little stories of patients throughout, which I think,
These are real patients with
yeah,
real names, real places. I don't like, and patient B from Plymouth said this. I want real people who are willing to come out and say their story. So these are real names of real people who are saying their story.
yeah,
Because they're, it's we're helping lot of people. We got there very early on. I started telling my practitioners all start treating long COVID as soon as you can. We, in our clinic in Manchester, we never closed down one day. We got
wow,
PPE, we had plastic covers. I changed, I did like a surgery every day for my patients. I scrubbed up, I changed my clinic tunic each patient, and we managed. And people gasped at how can we carry on? I said we have to. These patients need us.
so should we, it'd be good
And
to
by the way, nobody was hospitalized of any of our patients in the whole
really,
not,
wow.
never mind actually people saying that we're going to kill patients by keeping open. We had no practitioner and no patient hospitalized with COVID
Wow.
the whole
That's a
pandemic.
that's a that's a that's a proud feat, isn't
Well,
it?
well, we followed procedures and we followed PPE and we followed,
Mm.
cleanliness and
Mm.
we did everything
So
the right way. And we
how would we, with the Perrin technique? I mean, we've mentioned it. It's something that you've obviously developed. It's got your
mm,
name on it. What is it?
right. Well, my name came about because I called it the osteopathic treatment of ME. And then there was an unscrupulous practitioner who actually was doing all things wrong. And he was definitely not one of our practitioners now. I think he ended up in jail, but
Oh,
he was the first person to call it the Perrin technique.
yeah.
It's something, I'm not proud of that he called it that. But then a friend of mine who's an intellectual property lawyer said the only way you can stop this from happening, stopping people doing the wrong things, is trademarking it and calling
Mm,
it. And so that's what we've done. And we're very proud that the insurance company that mostly insures complementary medical practitioners and allied health practitioners have only insured people to do the Perrin technique who are properly licensed. So we're in this country. So that's really good. And
mm,
we've got a registered trademark in this country now.
mm,
So this protects the name, and that's why we called it the Perrin technique. So my name is protected, my treatment is protected, and patients who go to practitioners will know that they can only go. You people using the Perrin technique license are people who are trained by me, and we license them to use the technique. So this is what the technique is basically a drainage system of the brain and spine. So
right.
all other, it's not standard lymphatic drainage. All lymphatic drainage basically around, there's different techniques. There's Foley, there's the Voda technique. There's lots of different techniques that basically stimulate the lymph. And there's lots of osteopathic techniques there's pump techniques that stimulate the lymph to move in the right direction. if it's sluggish. So it stimulates if lymph is actually sluggish to move better. But it's non-directional, a lot of it. And especially the pump techniques where we increase abdominal pressure, increase thoracic pressure, it's called thoracic pump technique. These go on the deeper lymph and they're non-directional. So if the lymph is working the wrong direction, because it's the nerves that control it are going wrong, then you do standard lymph drainage techniques and it makes the patient worse. So
Right.
basically, in a nutshell, sorry, hi. So in a nutshell, basically, if you actually, sorry, just somebody just came home from work. So if in a nutshell, if you actually drain the toxins in the wrong direction, you're going to make the patient worse. So a lot of techniques out there, massage techniques and lymph drainage techniques, do this and make the patient worse. Even doing standard techniques like cranial osteopathic techniques that are part of my whole Perrin technique, if it's done without the lymph drainage, it just moves fluid in a certain direction, but then it gets stuck. So what I've developed is a technique for using cranial techniques and lymph drainage that create a concertina effect, pushing up and down, creating a pressure in the main drainage points of the lymph, which is underneath the collarbone, into the bloodstream. And this treatment eventually creates what we call a siphon effect, where there's a pressure differential and it keeps on pumping in the right direction and pulling out all the toxins from the body that are causing the problem, including all from the brain and the spinal cord and the muscles. And
Is that because COVID or a virus or whatever might trigger all of these things off has made the lymph system get confused as to which way it should be pumping stuff?
no, actually, it's the COVID, the virus is the trigger. It's not the cause. The
Right.
post-viral conditions, ME, is never the virus itself. It used to be Epstein-Barr virus, what causes mononucleosis, infectious mononucleosis, they call it in America. We call it glandular fever. That used to be the main virus that they used to think triggered ME. So COVID triggers long COVID, yes. You can't have long COVID unless you've had COVID. However, the problem is there before. So there's a drainage system. That's why some people get ME, and some people don't. And a lot of people get billions have had COVID, millions have had long COVID. So why not everybody? Because if their drainage system works, they're not going to get long COVID. And women have more problems in this drainage than men. This is why women get ME more than men, fibromyalgia more than men, long COVID, and other things like lymphedema and lipedema. There's lots of other conditions affecting women much more than men because their drainage is affected more. Why? And that goes right back to my original theory. What I found was the whole of the medical world said there was no drainage of lymphatics of the brain. Why did they say that? Because there's a barrier stopping any large molecules getting into the brain called the blood-brain barrier. And that goes down the spine as well. And it stops any large molecules getting in. So if large molecules can't get in, we do not need a lymphatic system because that's what the lymphatic system is there for, mainly to drain away large molecules. Small molecules can go through blood capillaries. Lots of blood in the brain, so it doesn't need the lymph because no large molecules can get in. And then I thought, that's crazy. Every second of every day, huge molecules enter the brain. Hormones. Hormones are massive molecules. And the hypothalamus in the brain, the small molecule, a small organ in the brain, the size of an almond, in the mid part of the brain, the hypothalamus, measures every hormone. It regulates hormones by a mechanism called biofeedback. So taking the example I always use is insulin. It's both in female and male hormone. And the insulin is produced in the pancreas in the tummy, goes into the bloodstream, up into the brain, and then the insulin enters the brain, and the hypothalamus measures the insulin. Insulin is a huge molecule. So how can it get in? And it does, because the blood-brain barrier is not a very good barrier. And now we know there are 7 areas in the brain that are in the blood-brain barrier that are weakened. They're windows to the brain, not just of hormones and electrolytes like salts and sugars, but also toxins and viruses and spike protein molecules and other protein molecules that shouldn't be in the brain. And then there's molecules that are in the brain that fire off, that there's what's known as cytokines. Cytokines are the molecules in the body, that interleukins and interferons that attach to the virus, that say to the antibody, "QE, we're here," and then the antibody would attack the virus. These are used in chemotherapy all the time. And you know, when people have chemo, they have a lot of cytokine put into the bodies because the chemo, they want to make sure it attaches to all the cancer cells. It causes major problems with the rest of the cells and causes all these other problems, like hair loss. So if you have a large number of cytokines and they're not drained away, you're going to have this reaction, and the antibodies are going to attack your healthy cells, like an autoimmune disorder, which is what we see with long COVID. And there's so many things in long COVID that people are having, which is related to this lymph not draining away. Because what drains the lymph away? What drains the cytokines away? The lymphatics.
So there is a way, it is there, pushing it down.
Down.
So
There has to be, and
yeah.
it's discovered now. And there's been a lot of work. And when I published my thesis 20 years ago, there was no hard evidence to support this at all. The first evidence came in 2012 for mice, where we saw what's known as the lymphatics being discovered, the lymphatics of the brain. It was called the lymphatics because it's the lymphatics of glial cells in the brain. So it was called lymphatics by Professor Macon Nedergaard, and this was research done in Rochester. Do you know when actually it was proven this whole lymphatic system actually occurred in humans?
Mhm.
Do you know when? 2 months ago.
Oh my goodness.
Only 2 months ago.
Wow.
The paper came out, or just a couple of months ago, 2 or 3 months ago, a paper came out from Oregon, from a research team linked to a whole group of neurosurgeons who did operations for brain tumors. And they asked for 5 volunteer patients who were having brain surgery if they could go into their brain, inject a dye, and watch what happened. And they saw in real time the lymphatic drainage occur. So this was only proven
so
now.
it's proved that there is that system. So
Yeah.
it sort of moves on to my thing is that I mean, I know, osteopaths, it's always a funny thing whether it's on the NHS or not. Is it a complementary, or is it now more of a standard, which I think it is far more standard and acceptable. But is the Perrin thing, is that accepted yet into the NHS? Is it something that you
We're
hope?
trying. I've been desperate for years and years because so many of my patients, because osteopathy in England generally is private medicine and my treatment is private, I found really, really hard. So I always say that patients who can afford it pay for those that don't. So we make sliding scales in my clinic, and I've advised my practitioners to do the same. Whether they do or not, it's up to them. I can't dictate what they charge. But I've treated patients pro bono, and I just want to try and help people.
So there's evidence backed, as I think you say in your book.
Yeah.
You've
We
now
haven't got enough proof to actually say it's proven, because you need a very large randomized controlled trial,
yes.
placebo control, which is very hard to do with manual therapy, and we need a lot of money.
I was going to say, and who would pay for it? Because
Yeah,
what's in it for the pharmaceutical company? So it's always a very
exactly.
tricky one, isn't it?
Exactly, and there's a lot of people in the ME world, and even probably in the long COVID world, who will be against my work because I'm not a drug. I'm not a drug, so I can't make money.
I mean, and I think for many years when we started looking at ME, and many years ago we ran an online clinic. We ran online clinics, and we did one on ME, and it was very, very difficult. It was very, very controversial and created a lot of high energy from some
Well,
people.
my work's getting more and more accepted now, and in America, I go over a few times a year to teach and share my work with in research conferences and workshops, and I said a lot of doctors who are not even osteopathic physicians come to my my courses and love the work.
And I can completely understand that if they're in tune with the sort of the functional medicine side of
Yeah, absolutely.
medicine.
I mean, it's I'm not, I'm Katrina. I've never ever claimed to be the cure all. So if
No.
people watching this think, oh, I found the answer, I am part of the picture. We have basically besides the treatment, which is basically cranial lymph drainage and getting everything moving properly. Eventually, the drainage starts working. Then the hypothalamus, not being as poisoned, will start functioning better. Now, I always tell my patients, and this is a real takeaway message. I tell my patients, you always think of the jigsaw puzzle analogy, and I talk about that in my book. So the jigsaw puzzle, when you make a jigsaw puzzle, you should start with the corners first, then the edge pieces, and then the sea and the sky in the middle. So what are the corners of the jigsaw puzzle with long COVID and ME and fibromyalgia? So first is rest. You've got to have a period during the day where you totally rest, do absolutely nothing, just lie there with no sound, no light, just lying there. Now, if that's difficult to do, some people might need to rest from longer than others, but you should have a period where you totally rest and do nothing, and that calms down the sympathetics. But some people find it difficult. So I don't want them to rest because Dr. Perrin says rest. It's not going to rest. They need to relax. So think of something that helps them relax. And if that's difficult, then learn how to that. And then the third corner is meditate. So mindfulness, breath works, whatever, any type of meditation, you need that meditation during that rest and relaxation. And then the last corner is the most important, and that's pace. And I've said I was standing and shouting from the rooftops 30 years ago. I started my work with Emmy 36 years ago. And when they were saying you need to push, 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 the dreaded graded exercise therapy of the NHS, I was saying, no, you need to pace. And I stood up, I got thrown out of some places for saying you have to pace. And one professor once came over to me and says, by pacing, do you mean pacing up and down the corridor? I said, no, no. Pacing means half of what you feel capable of doing. So everything you do, you should think of, can I do double? And if the answer is yes, then you're doing okay. If the answer is no, I can't do double what I'm doing, you're doing too much. If the
And
answer is
that's
maybe,
generally accepted. That's sort of accepted now, isn't it? Practice
that is
that.
one of my little babies that has finally, after 36 years of jumping from the rooftops, has finally worldwide been accepted, the 50
Yes.
rule. So
Yeah.
that
And I think one of your stories is very much, I think it's probably maybe the first story. The lady, I think it's a lady, she said, and I've heard this so many times. The reason that my recovery has been slower is because I tried to carry on as normal.
there's no, yeah. And I don't make the rules, unfortunately, Katrina. I do not make the rules. The disease makes the rules. And
Mm.
people, the cruel part of this is, see, ME and fibromyalgia and long COVID are not the cruelest, are not the worst illnesses in the world, but I think they're the cruelest. They usually hit the type A personalities, the doers, the pushers. And they're the ones that I'm going to beat this. And willpower is going to get them through it. But willpower uses the sympathetic nervous system. And that's the nervous system balanced by the hypothalamus that is going wrong with ME. This nervous system controls the lymphatics. We were never taught that. In physiology, we were taught there's no neurological control of lymph, it's just tubes. But we now know very much different, that the lymph is controlled by sympathetic nerves and they pump the wrong way, they're going to cause this backflow. And they're going to
Right.
pump the wrong way when there's all this disturbance. And that's the hypothalamus. So we get the hypothalamus working, it gets the sympathetic nervous system working, it gets the lymph working. But if you overload the sympathetics during the time, you're going to get nowhere. So you've got to
Right.
back off. And that's why it's so important. The rest, relaxation, meditation, pacing. And then the edge pieces are the Perrin technique itself. Getting the neurolymphatic system working, getting the lymphatic system of the brain and spine working better using my techniques. And then the sea in the sky is all the extra bits, the functional medical parts, the diet, the nutritional side of things, maybe supplements, maybe talk therapy, all these other things, and even medicines and pharma. I'm not against them if they're needed, all those might be necessary as well. But that's the jigsaw puzzle. And some people are a 10-piece jigsaw puzzle, they're easy. Some are 100-piece jigsaw puzzles, and some are 10, some are 1,000-piece. I've got one patient, she also says she is so complex, she's the baked bean jigsaw puzzle. You know, the one it's 1,000-piece jigsaw
Yeah.
baked beans.
So,
And
and
you,
your
yeah,
book covers all of those things. It covers the techniques.
yeah.
Is it something, a technique, and I know there's a lot of stuff in there that explains how you do it. Is it something that you could do yourself, or is it something that you recommend you do go to a practitioner to start with to give you the basics to make sure you're doing it correctly?
Yeah, you should get it checked by a practitioner to make sure you have the physical signs that that I have discovered with these conditions. So it's important to have a diagnosis that's positive based on the physical examination. So it's important first to get a diagnosis from a practitioner who's licensed. Um, then after that,
When you say diagnosis, you mean a diagnosis of long COVID?
yes, yes,
Yeah, right.
yeah. So we don't diagnose it by exclusion, we diagnose it by positive signs that we've seen in these patients. So if they don't have the physical signs, they don't have ME, they don't have fibromyalgia, they don't have long COVID. If their physical signs aren't there, and there's 5 major physical signs, and they're in the book. But
Yeah.
the thing is that even if they have that, they should start with the treatment, and if they can, find a practitioner near them. I'm training up practitioners all the time, so there might not be somebody close by, but if they know a local practitioner, an osteopath, of chiropractor, physio,
How many are there in the UK, would you say?
probably around 100 in the UK,
Right.
and altogether about 100 in America, maybe more. Altogether about 250 in the world. So it's not a lot. I'm trying my best to train up, and I'm also training advanced practitioners who will eventually take on take on some of my work and start teaching it to others as well. Because I don't want to have when I leave this world, I would like it to leave where this technique continues on and helps others in the future. But the technique I've been doing for 36 years, it helps a lot of people. I said it's not a massive cure, but I'm saying that with the jigsaw puzzle, you know, it goes back to that. You can start with other things first. You can start with the middle pieces, but it's much more difficult to finish a jigsaw puzzle of health.
Yeah, it's much better to get the whole look of it
Yeah,
and then start treating
and
it.
work out what to do.
Yeah.
So get the sympathetics dampened as much as we can. We get the treatment working to drain off the toxins, and then you add other things to it, to the equation, and we help. I said, thankfully, I help most patients. You know, we have a busy clinic in Manchester, and there's sometimes every patient who's coming in might be 10, 20, 30 patients in a day coming in, and they're all improving. And I challenge that with to any clinic in the world to have that all the patients are coming in are being improved with the treatment.
Yeah.
Not always happens, but we have very few patients we don't help, but there are some. And those ones, I'm sorry, and it's a shame, and it's also very sad for me that they've had to pay out because it's not NHS for treatment that's not worked with them. But usually we try and find something that does help. But most patients we help, and that's
Yeah,
all we can do. We can all
that's good.
try and help.
And I don't know if this is how long's a piece of string, but how many treatments would you have to start seeing that improvement?
Yeah, it's very much a how long is a piece of
Right,
string.
okay. I thought you might say that.
Yeah, no. Right, okay. So we have a scale. See, when we diagnose the patients, and now most patients with long COVID have had it for a few years, it's really morphing into ME. And you can find that they've had problems before, they've had traumas before, they've had physical traumas, emotional traumas, immunological traumas, they've had infections long before the COVID or long before the illness that triggered the ME. And it's a build-up. And a lot of people might think, oh, well, I had a whiplash injury years ago. That had nothing to do with this, but it actually might have affected the drainage. They might have had trauma when they were kids. They might have, at birth, they might have had a trauma at birth. So all these things build up. And we work on the how long the person's had the symptoms for, how many, if they've got any other comorbidities or other diseases, if they've got their functional life, their quality of life, how they're functioning. Are they working? Are they bedbound? Are they sort of confined to bed? Are they confined to the house? And these are things that we will look at and eventually work out a score out of 10. So we have the symptoms, and all the history gives us an
Yeah.
idea, and then the physical signs are the final bit of the picture. So we have a score. 0 is, I always say to patients, you're not 0, because 0 is dead, and they come in and I say, well, you're definitely not 0. So usually we get a smile from them, and because they're not depressed, they're just fed up. And
But I understand it's a scale that allows you to measure, well,
yeah,
starting point and how you
and,
improve.
yeah, and then if there's so a 5 out of 10 might take about a year to get as well as possible. It might be a bit longer. Lower down in the scale, when they're closer to very severe, if they're 3 out of 10, it might take 2 years. But we never see patients who are more than 7.5 out of 10. Because
Yeah.
there are lots of 8s out of 10s there walking around thinking they're tired every so often, but they're living with it.
Yeah.
But we
Yeah.
see the patients who aren't living with it, who are struggling.
Mm.
And so we did a survey a few years ago looking at it, and we showed 90% of patients improved. And the average patient was around a 4 out of 10 when we saw them, and they finished after treatment to a 7 to an 8 out of 10. So we
Mm.
help those people get back to life and back to work and back to the,
Excellent.
yeah.
Good. Well, thank you very much for your time, and I wish you well, not only with the book, but more importantly, with the Perrin technique.
Well, thank you
And
very much.
look forward to seeing that if lots of people succeeding, getting much better, that we do get it into the NHS.
Well, that's the thing. We are doing studies. I'm doing studies with my colleagues at the University of Manchester, and we have a study that we're ready to, is just about to hopefully publish soon on self-massage routine that was done within the NHS framework. And that's where they're really happy, because it's all done self-massage and self-exercise. And that helped some patients. It improved their symptoms. And it was a feasibility study, so we need to do that first before we go to a full randomized control trial. But that was within NHS, so hopefully some part of my work will be in the NHS one day. Yes.
Well,
Thank you.
thank you.
Thank you. All the best. Take
Thank
care.
you.
Bye bye for now.